Hello and welcome to the Gonzalez Mitchell Show. I'm Clay Mitchell. Today, we have a guest that's going to talk to us about an important topic. That's about the rising cost of hospital care and medical care. Joining us today is Peter Pitts. He's president and co-founder of the Center for Medicine in the Public Interest. He's a national healthcare expert who has spent years researching hospital pricing and non-for-profit hospital accountability. And he's going to help us understand what's driving up these costs of healthcare and what policy tools may be available to us to help get those prices under control. Peter, welcome to the program.
Thanks, Clay. My pleasure.
Now, for those who don't know you and what you do, give us your background, what you've done in the past, and what brought you to be the head of this Center for Medicine in the Public Interest.
Sure thing. Well, first of all, let me mention that I was a longtime Bethesda resident when I lived in Maryland. So, I understand what Maryland is all about. It's many different types of states in one mid-sized state. So it's important to talk about this topic. As you mentioned, I was an FDA associate commissioner during the George W. Bush years, and I'm now president of the Center for Medicine in the Public Interest, CMPI, which is a not-for-profit group that focuses on basically how to advance healthcare in this country over a number of different platforms. And the reason that, and it's cmpi.org for the folks that want to check us out, but the reason that hospital talk discussions are so important is that hospital costs are about 35% of the healthcare spend in the US. People always think that it's drugs, but it's really hospital expenses. So if we don't talk about it and make it better, the healthcare spending in this country is going to spin out of control. And even more importantly, the money is going to be spent in the wrong way. So we've got to understand what's happening so we can spend our money more wisely.
Now, there's different systems the way hospitals are reimbursed. And it's my understanding is that Maryland is unique among the 50 states, at least until this point. Could you tell us what that's all about?
Sure. Well, when it comes to hospitals in the US nationally, about 60% of all hospitals are not-for-profit hospitals. And I'll get to in a minute what not-for-profit means, because it isn't what most people think it means. And you have to ask yourself, remember back in the Depression, there was a famous bank robber named Willie Sutton. And he was asked, why do you rob banks? And he said, that's where the money is. And that's why hospitals are so important. And that's why this whole nomenclature issue of what not-for-profit actually means becomes really important, because you think that not-for-profit means everybody's there for the public good, that there's no profits to be made, that all the money is put towards patients versus overhead on executives, and they don't have to advertise, or they don't have to lobby, and all those things that you think are true are in fact false. So we really have to shine some sunlight on the system to understand what's going on, so that the money that goes into not-for-profit hospitals, which is overwhelmingly money from the taxpayer, from our pocketbooks, it needs to be spent more wisely, and not-for-profit needs to translate into focusing on the patient versus where a lot of that money is going towards these days.
Again, you say non-for-profit, but it's my understanding that by serving the public good, quote unquote, these hospitals get significant tax breaks and preferential tax treatment. Is that correct?
Oh, amazingly so. And so you'd think, with the reason that these large hospitals, I'm not talking here about mom and pop hospitals. We're talking about all the big hospitals across the country, and certainly, in Maryland from Johns Hopkins on down. You'd think that, that you wouldn't have executives being paid millions of dollars a year. That's incorrect. Not-for-profit hospitals nationally and in Maryland, the executives are earning top dollar. So, and that's a question mark. You'd think that the money is going towards doctors and nurses and the technicians and the guys that push your gurneys in the hospitals, the people that really mean care to the public. Not so. You'd think that money will be given towards enhancing patient care versus having more executives driving Mercedes and parking in the parking lots in hospitals. Not so. You'd think that not-for-profit hospitals wouldn't have to lobby. They do. You'd think that they wouldn't have to advertise. They do. You'd think that they would prioritize patients with lower net worth. Not true. So it becomes kind of, I don't know whether you're a fan of Firesign Theater, but
Yes.
they had this record years ago called "Everything You Know Is Wrong." And when it comes to not-for-profit hospitals versus for-profit hospitals, there's really very little differentiation. The management business models of not-for-profit hospitals nationally and certainly in Maryland are more or less exactly the same as for-profit hospitals, and that causes an upside down divergence in patient care that needs to be addressed.
How do we end up here where, as you say, we have executives making upper six figures and seven-figure salaries? How is that allowed to happen? Does it have anything to do with the insurance industry, or they have just been allowed to get away with it?
Well, I think that, obviously that's a complicated question, but I think that
Yeah.
the baseline answer is we haven't been looking hard enough. And the not-for-profit hospital industry, because it really is a business, has recognized they can say things like, well, we're the guys with our names on the back of the Little League uniforms. We're the guys that sponsor the parades, in our various cities. We're the good guys here. And I think that's a real devious untruth, because what the management of these hospitals are doing is that they're clothing themselves in the good deedism of their doctors and their nurses and their staffs. And don't get me wrong, the professional staffs in these hospitals, regardless of where they are in the country and how big the hospital is, these guys do God's work. When you go to the emergency room, when you get treated in hospitals, you're getting great care at a not-for-profit hospital, and it really isn't because of the MBA sitting in the CEO's office or the MBA sitting in the CFO's office. It's because of the doctors and the nurses and the techs who are doing the job every day, providing great care. But the reality is, just because the name of the hospital is on the back of the Little League uniform does not mean that these guys are doing it because it's the right thing to do. They're in it because they're getting big salaries, and the whole system has really been turned upside down, because the whole concept of not-for-profit hospitals, as you mentioned earlier, has just really been forgotten. These units are being run like for-profit businesses, and that's got to change. Not the least, and again, you want to look at why this is true. Is look the amount of money not-for-profit hospitals spend on, ready for this, lobbying.
Yeah.
And advertising.
Yeah. The model that Maryland has, my understanding is that we have a board that actually sets the pricing for hospitals. It looks like, from what I've read, that we're getting ready to shift over to a federal, what's called the AHEAD model. Could you explain what the difference between the two is, and whether we're heading in the right direction or the wrong direction, or is it just a status quo?
Sure. Well, the AHEAD model is very focused on reporting. And I think that's great, because, as I say, if you can't measure it, it doesn't count. But asking hospitals to report, supposes that you're actually asking them to report on things that make a difference, and that gathering information is the end game, and it's not. Because first of all, you've got to get in the right data, and then you've actually got to act on what that data says. So, for example, you mentioned earlier, reaching out and serving those most in need. That is not something the AHEAD model focuses on. The AHEAD model focuses on, talk to us about the patients that you've served. Now, when it comes to not-for-profit hospitals, they're exactly the same relative to for-profit hospitals. Is they'd rather serve well-insured patients than patients who have no insurance or who have bad insurance. Why? Because they get higher reimbursement. That's got to change. In the AHEAD model, while a good step forward, doesn't really incentivize hospitals to reach out and give charity care. And that's really what this is all about. How do large not-for-profit hospitals do best for those who need care the most and can't pay for it? And that's when you begin entering into this thing called the fair share gap, which is, how do not-for-profit hospitals deal with the uninsured, underinsured, non-insured communities versus those who have higher insurance and therefore would give greater return to a hospital's bottom line. And there really is what's called a fair share gap, which is the difference between the amount of public money a hospital takes in versus the amount of charity care that it provides.
I imagine the insurance industry has an opinion on that. They're giving insurance to the well-insured, as you say, but then again, indirectly or maybe directly, those insurance premiums are paying for those underinsured or not insured people who are in need that can't get insurance.
Yep.
What
So
do you see as a vehicle to correct that, to close that gap?
Well, I want to go back and give you more detail on that, but I think that the direct
Sure.
answer to your question is what can we do to make these hospitals do the right thing? The first thing is name and shame. If people knew what was going on, they'd be angry. And as I mentioned earlier, not-for-profit hospitals do a great job on the PR front, kind of hiding behind the white coats, so to speak. But nationally, 80% of hospitals, not-for-profit hospitals, spend less on community benefit than their tax breaks. Now, to my mind, and there are lots of ways you can argue how much of their tax break should go towards the public good. To my mind, it should be like almost 100%. And if it's not, why is it not? And you've got issues like executive salaries, and you've got things like empire building, like in any big business. Now, Maryland does better because, as you mentioned, the amount of public hospitals in Maryland are higher percentage-wise than most of the other countries, like 80% in Maryland versus 60% nationally. So all big numbers. But how do you make these institutions say, listen, we're in business to help everybody, but those who can't afford it need an extra, hand up. We need to help them more. We need to go out there and actively solicit people that can't afford it, and that's not what's happening. Hospitals, not-for-profit hospitals nationally, and also in Maryland, spend hundreds of millions of dollars in advertising and marketing, soliciting people with very robust insurance. Why? Because they make more money. They actively try to, skirt those who need help but can't afford it. And that also oftentimes results, and certainly does in Maryland, hospitals aggressively pursuing people that don't pay their bills but can't afford to. So, on the one hand, they want to have their names on the back of Little League uniforms and be seen as the good guys. And on the other hand, they're sending lien notices for minimum wage workers' jobs to garnish their wages. This is not the way it's supposed to work.
Now, 15, 16 years ago, we passed the Affordable Care Act, and there was great hopes for that. I think it has done some good, but there's been some shortfalls with it. With the Affordable Care Act, has this helped the situation, or has it exacerbated the situation? Meaning, we were saying 250% increase over 25 years. That's a chunk of change. Has that helped at all, or do we need to go back in and revamp that system?
Well, the Affordable Care Act is one of these mega pieces of legislation that nobody understands, least of all me. But what I do understand is when you put a lot of codicils in place that restrict how hospitals can make money, they simply look for other ways to make money. And it's like putting your finger in the dike. You have to really understand, if a hospital system is bobbing and weaving to increase its bottom line, how do you plug those holes? And I think you mentioned the AHEAD situation. I think that's a good way to start. But I think that the most important way to really begin this conversation is for the public to understand how not-for-profit hospitals make money. And it isn't necessarily by serving those most in need, because that's not where the money is. Like I mentioned earlier with Willie Sutton, the famous bank robber. For example, if one way a hospital says they're going to streamline their operations is to pay their CEO and their CFO and their managing directors literally millions of dollars a year, there is something wrong with this model. And for those hospitals to say, well, we need to be competitive with for-profit hospitals, you have to ask, no, you don't. You're a not-for-profit hospital. You're not in business to make money. Obviously, you want to run a smart operation. You want to be lean and mean. But why doesn't all that money result in more doctors and more nurses? Why are not-for-profit hospitals running with fewer doctors and fewer nurses. It doesn't make any sense. Where's that money going? And when the answer is to people that don't provide care to patients, something's upside down. So the Affordable Care Act, I think, facilitated this upside down dynamic of where the money goes. The AHEAD proposition, I think, is a step in the right direction in the sense that it demands metrics. But I guess the question is it demanding the right metrics, and does it drive better behavior? And I think the answer to that, at least right now, is not yet.
And one of the things near and dear to my heart is the rural hospitals. They've been closing down this country at an alarming rate. And also, when you talk about those in need, when you talk about some of the inner urban areas where there's an underservice of medical care, if you could wave a magic wand and correct this in any way you wanted, money's no object, what would you do?
Well, if money was no object, I'd make sure that people got earlier preventive care so they never ended up in the hospital. But relative to rural and small communities, this is really crucial because those not-for-profit hospitals are going out of business. And you ask yourself, how could a not-for-profit hospital go out of business? It's not supposed to make a profit. And the answer is that they simply, just as with for-profit hospitals, large hospitals are buying up smaller hospitals, and the money is not being plowed back into more care, more aggressive care, more availability of care in small and rural communities. It's going into exactly less care for those types of communities. So again, any type of law or oversight you put into action has to not only focus on kind of cost control, but also the dynamic of making sure that rural hospitals and small city hospitals get aggressively funded, which they are not. And relative to the Affordable Care Act, again, it's not surprising because when these units realize that Medicare and Medicaid patients you can't make money on these patients. But the result isn't, okay, well, let's make sure the money goes into underwriting that type of care. What hospitals are doing is saying, well, let's not try to provide that care at all. And that's a for-profit dynamic, not a not-for-profit dynamic. And that's what happens when you have executives from private industry, being paid millions of dollars a year, being put in charge of not-for-profit hospitals. They behave like not-for-profit. They behave like aggressive for-profit entities, and that shouldn't be a surprise.
Peter, when you talk about accountability, is there a way for the public to find out what these salaries are, who these people are, what they're actually doing, and what they're spending money on? Is there a way to find out what that is?
Well, let me point our listeners, our viewers, to the Center for Medicine and the Public Interest website, cmpi.org. We've done a whole bunch of reports, national reports, state reports on this very topic. And one of the things we often start with, because it's sexy and gets people's attention, is executive compensation. And we footnote our sources. This is all public information, so it's kind of shocking that more local reporters haven't gone into it to look into it more deeply. I know the Baltimore Sun has done some, analysis, but how many reports can you write on, the absurd, the excessive, the almost imperial salaries that not-for-profit hospital executives make, the non-medical ones? But it's out there, and newspapers and news stations do a good job, but they rarely ever follow it up. And again, oftentimes when the annual report gets posted, that's when hospitals start talking about little league teams and helping build playgrounds and hiring more equitably. They try to say, don't look here, look here, but right. the behavior doesn't change. Hopefully, the AHEAD situation helps drive metrics because if you can't measure it, it doesn't count. But you have to be measuring the right things.
What is your website again, in case someone wants to go in and look those things up? What's your website?
Oh, thanks. It's www.cmpi.org.
Great. Well, Peter, I'm looking at the clock on the wall, and I'm afraid our time for today is coming to an end. This is the part of the show where you and I have to say goodbye, Patrick.
Goodbye, Patrick.
Goodbye, Patrick, wherever you are. Peter, thank you so much. If there's any developments in this field, please give us a call. We'll have you back on. Thank you, my friend.
Excellent. My pleasure. Thank you very much.